If all else failed, if you treated your patient with a lot of different medications, then I would consider biopsy, or if you're really not sure. But a biopsy is a necessary scar that you've given somebody in the event that you just didn't take it one step further with history. My attendings told me that 99% of diagnosis was history, but not many people take the time to talk to their patients. And you're nervous when you come to see a doctor. Disarm your patient. You're a physician, you know how to do that. And then when people are relaxed around you, they go, oh, well, let me tell you what really happened. And it's not that they're hiding, it's just you don't know how to express it. You don't know what you're asking for your patients. Most people come in and tell me they've used Vaseline most of their life. And I'm like, Vaseline is pretty much a waxy ester. So I'm glad there's certain products like CeraVe, Cetaphil now have come out with healing ointments on the same level of a Vaseline type of treatment. So it's moving with what people can relate to and like. But there are a lot of great products out there that I've used even before I've hit medications. Mm-hmm. So mild atopic dermatitis doesn't have a lot. I mean, they're very itchy, but not very scarred. Not a lot of plaques. You start going, what are you doing treatment-wise? Fragrance is the first thing that I take out of people's lives, and not just with the lotion and not with just soaps, but even detergent, fabric softeners, dryer sheets. I've had people go, I use all clear, and I go, that's nice, but do you use dryer sheets? And they go, of course. I want it to smell good, defeating the purpose. You have to change everything. I'm not that person that doctor says you can't take a bath or a shower every day. Just to be conscientious of how you do it. Don't take a hour-long hot shower. Decrease the time, decrease the temperature, and use different products. Like I said, I like La Roche. I like Cetaphil Restore, moisture restoring wash. All those washes are great. They're not just the hypoallergenic washes that don't lather. So they do lather, but they don't have scents, and they do hydrate the skin. After that, you do want to lotion up. A lot of people tell me I don't want to feel sticky all day. Then do something that's lighter. There are lighter versions of those lotions as well. La Roche has a triple repair one. The Cetaphil lotions are also not as thick as like the traditional Nivea or Lubriderm washes. Vaseline has an intensive care one that isn't as heavy. There's different ways that you can approach it. I do believe in giving a cortisone at first, though, even if it's mild to moderate, because you have a child that's scratching or an adult that's scratching, you don't want to lead to infections as well. So you try to spare from a cortisone. That's a misconception that if I give a cortisone, it's going to thin out. How long does it take before your skin thins out? We're not delicate little dolls. We can do it for a certain amount of time, and you just teach your patient. 2 to 3 weeks, twice a day, medium, moderate level corticosteroid.
What is that percent?
So triamcinolone is a really great moderate one. So is desoxymethasone or Topicort. Those are great, and they moisturize the skin. At that same time, you're trying to think, how do I get them off of this cortisone and to maintain without a corticosteroid? Because long-term exposure can thin out the skin and atrophy the skin. But you're following up with your patient, you're educating them that don't do it that long, and introduce a non-cortisone cream. And a great example is your Eucrisa. Those are the phosphoesterase 4 inhibitors. And they're the newer forms of the topicals that are non-corticosteroids, so non-atrophying of the skin. And they can stay on those, and studies have shown that they can stay up to over a year to reverse the effects of atopic derm. So let's get them out of that chain. And of course, antihistamines. You want to stop itching as much as possible. I like Zyrtec, I like Claritin, but I mean, you want to be able to do that mildly. I do it in 3 to 4 weeks.
Okay.
And I get them right on the Eucrisa.
Okay.
But there are people that, everybody's not the same. So then you might have to come back in and be like, oh, you didn't work the Eucrisa. Let's try Elidel. Let's try Atopic. And then you put them back on maybe for a week or 2 and try to wean them onto that. There are newer forms of meds coming out all the time. If you don't have barrier repair for the skin, and your skin is the largest organ on your body, so you want to make sure you take care of it and don't lead to infection, or if you do break down the skin, let's say you're scratching a lot, you open up the skin, we have microbes that pretty little microorganisms that live on our skin naturally, staph and strep. So you don't want them to all of a sudden turn on you either. You want that barrier to stay intact, because if not, allergens and pollutants also now enter the skin and break down and inflame the skin as well. There's also prescribed emollients like Episerum, Luxamed, Biofen. They're great for putting emulsion back into the skin as well for people who have a really hard time of getting that emulsion back in. Hyaluronic acid-based products are a great source as well.
Nice. Oh, we're learning so much on this. Hard to keep up with all this. So tell us, can you give us the ABCD approach, non-pharmacological interventions to atopic dermatitis? ABCD.
ABCD. So pretty much taking away fragrances, taking away allergens. Not every perfume is bad, but you don't want to spray it all over yourself. Some people, if they can get away with it, spray it on the clothes the night before. Like I said, we changed the products, we've changed the wash and all that. And then we start to do, let's go look at allergies. What are your basis of your allergies? A lot of people, especially in our community, don't visit allergists. Go to an allergist and see, instead of trying to guess what you need to avoid. And it's not just seasonal allergies or environmental pollutants. You also want to be able to take away like certain products that you might be allergic to that you didn't know. It's not that every woman can't do mascara, but you can't do a mascara that has Quaternion 15 in it. So you have to figure out what that is.
And will an allergist be able to tell?
Absolutely, especially with patch testing and Ross testing, where they do prick needles into the skin to see what you react to. But I mean, like I said, it's different based on your community. Like for our community, going back to what we were talking about, well, is it race related? I look at the different things. Is it genetics that make ours worse, that makes it more prevalent? Genetics, environmental causes, like pretty much, race inhibited kind of diagnosis in medicine, and pretty much where people live. So the shortcomings on, okay, so if I live in a place that has more environmental pollutants, does that mean that I'm going to have more pollutants? Yes, it is. If I'm not taught that I need to avoid certain allergens, yes, it is. So all those things that you have to take into consideration. And there is a mental stigmata that comes with atopic derm. And you see it with kids that don't want to go to school, shut-ins, conduct disorders, behavioral disciplines. And it's actually associated with ADHD and some forms of autism. So you got to be careful, especially some people don't actually want to go to work. So you're starting to affect economic lifestyles.
So in terms of the ADHD or the autism, do we know what the relationship is? Is it?
So they talk about behavioral, they talk about this intense itching for the atopic derm, and they're constantly itching, so you can't focus on other things that are right for you, because it's that itching that won't stop, especially as you get to the more severe forms of atopic dermatitis. And so that's when you have to start thinking about stronger medications, whether it be oral or biologics. There are different meds that have come out. Opzelura is one topical that's a JAK inhibitor, and the JAK inhibitors are the Janus kinase inhibitors. They're pretty much the inhibitors that are like a valve. I'm going to stop all the inflammatory reactions, all the cytokines, instead of targeting one particular enzyme or interleukin that could be the specific cause for atopic derm. But one of them is Opzelura. Opzelura just recently came out, but it's for ages 12 and above. And even though it's a topical, it does carry side effects like other JAK inhibitors, possibility of blood clotting, or with your upper respiratory tract infections. Oral ones like Rinvoq or Cymbuco also came out in their JAK inhibitors, but they also are associated with heart disease, stroke, immediate death, or risk of blood clotting. So you have to be careful of them. You have to look at your patient at that point and say, are they a candidate for these meds? Biologics are great. Dupixent is very popular, and Adbry is another one that just came out, but those are the interleukins. It's going to target something specifically, interleukin 4, interleukin 13. And they carry less heart side effects, but more so injection site pain that can come with it, pink eye or conjunctivitis, or sometimes upper respiratory tract infections. But they're a little bit more or less harmful. But then you have to get past whether your patient would rather orally take a med or inject themselves. And that's another psychological issue you have to deal with. No one wants to inject themselves. But then more and more people, I guess, are becoming more affluent about biologics. So just trying to figure out what one works for the other. So there's no problem. I would try to, first you have to get them approved for the drug. They are very costly. So you would have medication coverage for that. But then I would start them off with a high potency cortisone, like halobetasol, clobetasol, and then sometimes oral prednisone or an intramuscular prednisone injection that kind of calms it down, trying to get them that long-term biologic. And if I can get that biologic, it's fine. Methotrexate, cyclosporin, Imuran, or other systemic alternatives that you can treat atopic derm with. Going for the antihistamines at the same time. But I mean, if you keep scratching, like we said, we lead to scarring, and sometimes prurigo nodularis can come out of that, which is this pretty much scar bumps that come from constant scratching. There's actually a new biologic that came out for that, Namluvio, that's really good. So there's always something else that can come out to treat even that further down the line, the sequelae that comes from atopic derm. So photobox is UVB lights, UVA were really more of a in the past kind of go-to as a first line of therapy. It's hard to buy a $50,000 box and keep it in your office. Worry about radiation, insurance reimbursement. Who's paying for this box? And then, of course, for our skin, you don't want too much UVB exposure because the risk of hyperpigmentation or scarring does come with being in that light box. So it's more antiquated like we were discussing before, but I mean, it still has its place. It does work, especially if you can't do anything else. It will decrease itching in your patient. Definitely asthma, seasonal rhinitis, seasonal allergies. And then we go down to lifestyle, which obesity is one of them. How is your gut flora? And we talk about gut microbes. We're talking about, does that affect atopic derm? It does. People who are constantly given antibiotics and you start to disrupt the normal gut flora, you want to maybe give them probiotics to try to turn them around. And they have noticed that if it's starting in infancy, maybe their gut flora was already disrupted by the time that they were born. There are a few foods you can turn around for kids to try to get that gut flora to replenish and get that gut microbes to go back to normal. Bananas, artichokes, and soybeans are some of the 3 things that you can do. We were talking about before Biofen, no, sorry, not Biofen, but Biofen's more older. Episerum, Lexamed, those are the new skin or wound repair creams. You use them for wound care, but you can use them for people who've scratched a lot. That on top of that is topical mupirocin, which is a topical antibiotic ointment that's used to treat staph and strep. Gentamicin is also a great alternative. Niacinamide or, triple antibiotic or neosporin, less likely because there's so many of a percentage of the population that's still allergic to neomycin or bacitracin. So I think that mupirocin is a better way to treat those infections.